Okay, so I wanted to talk a little bit about refusals. One of our chart review items we've been doing is looking at refusals, and our documentation with City Fire and with the ambulance is not very good. And so we need to kind of improve on that, and I just want to talk a little bit about it. So why is this so important? About 50% of all pre-hospital lawsuits revolve around refusals. And I think it's kind of good to think about that as far as the risk involved. So there's the low risk, high frequency things. So in most of these kind of things, there's, low risk with letting people sign refusal. We kind of do that stuff all the time. Things we're really good at. We're good at talking people into going to the hospital when they have chest pain. We do chest pain stuff all the time. We want to make sure we hit all of our goals for treating patients with chest pain, but in general, our risk is pretty low. Then you look at the things that are like highest risk, low frequency. So that's like our surgical airway management in general, actually, maybe, depending on how busy you are, your individual experience. But also looking at things like pediatric codes. So those things are the high risk, low frequency things that unfortunately, even though these things may go to court, you may do everything right and have a bad outcome, you can still get sued over. And then there's the high risk, high frequency. And this is where a lot of lawsuits come under, is like things we're doing all the time that are the highest risk that are high frequency, and maybe there's an attitude of kind of complacency in those things. So we want to be really diligent all the time with our refusals. And it's kind of good to think about that matrix all the time when how you're training for things like surgical airway, something that's high risk, low frequency. That's something I want to review all the time because there's high risks associated with it. I want to be good at it when I actually have to do it. In our careers, we may only get to do a couple, maybe even more, maybe slightly more common chest decompression. Again, something we're going to talk about later tonight. Maybe higher risk, but low frequency. So, all right. Anyways, enough of that. So the people, we're at risk for this, and the things that are associated with a lot of these bad refusals are, the busiest units, the time of day, early morning, and that, is like 3 a.m. to 7 a.m. Tends to be high risk. Our frequent flyers, they're kind of like playing Russian roulette, right? Because, 90, say, one patient who may have 145 ER visits last year, in one of those visits, he may have something he's going to get admitted to the ICU for. So a lot of those tend to involve alcohol, so we have to be really diligent and careful with refusals in some of those settings. So our frequent flyers are actually one of the highest risks for litigation and not having good refusals documented. So, and then belligerent patients, because nobody wants to take care of those folks. It's easy to blow things off, so you really have to use all your verbal judo skills to deal with those people. Enlist their friends and family to help deal with them and get them calmed down. And when that fails, you can use actual judo. Right? So, go. I put this up here. These are general ethical principles, just to remind me, maybe even more than you guys, is that first we should be doing no harm. That should be our goal. If something we're doing is causing more potential harm than any benefit we're getting from it, we need to re-examine that. We need to act in good faith. So. When we're treating someone, we need to be doing that for what's best for them, maybe not always best for us. So when you're tired, frustrated, and you want to just ignore something, but don't ignore things, and we're acting in the patient's best interest. So those are good things to remember. I put in just some basic legal stuff to remind us all. So civil law, again, is concerned with establishing liability. This is where we get sued. The patients can sue for a perceived injury. Most EMS lawsuits, again, involve negligence, and the others involve potential tort, and we'll talk about what tort is just briefly. And then criminal things are where the state is prosecuting you for a criminal act, a violation of state statutes. So, negligence, so a tort, negligence is a tort, and a wrongful act it constitutes tort. And negligence implies that it wasn't intentional necessarily, but it's a failure to act as a reasonably prudent person would act in a similar situation with similar training. So as a paramedic, you may not be expected to do the things that I would do as a doctor, so always remember that with my feedback too, probably, but anyways. You would be expected to act as a reasonably prudent paramedic would under the same circumstances. So, there are 4 elements of negligence. So first of all, there's a duty to act, and while on duty, we all have a duty to act. Sometimes in a situation for you guys where you might be putting yourself at risk, you actually do not necessarily have a duty to act in that setting. So you don't have to run into a burning building to pull someone out, and no one would should legitimately fault you for not doing that stuff without proper protective equipment. Now for the fire department, that would be an expectation. And the police department, there are different expectations. So, but you have to have that duty to act, and while we're on duty, we do have a duty to act. So a breach of duty, so that's either an action or omission that occurs in taking care of patients that results in some kind of harm or damages. So that can be emotional stuff. It can be actual harm or death. One of the lawyers I talked to, he says it's always best to have a live patient suing you than the family. So just anyways, so that should always kind of go into your decision making too, Anyways, but and then there should be a causal relationship between the act or omission and the harm, and that's the things that have to be proven. Those 4 elements for civil. So the standard for civil lawsuits is different than criminal. So does anyone know the difference between the standards between civil and criminal? Yeah, so you have to break the statute, but what's the burden of proof? Oh man, this is like legal class. Go ahead.
The burden of proof in criminal is on the prosecution.
Yeah, beyond a reasonable doubt too, right?
Usually, yes.
Yeah, for criminal.
Mm-hmm. And in civil law, if you sue me, I have to prove that I didn't do wrong.
Exactly.
You don't have to.
And it's only by the preponderance of the evidence for civil law versus the beyond a reasonable doubt. So there's a lower standard. So just remember that too. So, an intentional tort, sorry. So this is less common in EMS lawsuits, but this is things like assault. So inflicting or threatening to inflict any type of harm. And battery, which is any kind of contact with the patient without permission. Unlawful imprisonment or kidnapping is keeping or transporting someone without their consent. And defamation is the lowest risk lawsuit for us, but that's where you basically tell someone about something or you write something about it. So if it's verbal, it's slander, and written is libel. So hopefully that's all the law stuff, because I can't stand that stuff. Good. So. And I just had to remind us about consent. So we should always be trying to get informed consent. It should be obtained from every adult with a decision-making capacity. So we need to describe the problem and the treatment, discuss the risks, kind of benefits and alternatives, and advise of the consequences of action or inaction. So that's what we should be doing in general for all the people we see. Parental consent, that's obviously when a minor is involved, a parent or legal guardian can provide that. Implied consent, I think still something we should always remember exactly what that means. You can't just always use implied consent. It's when the person is unconscious or too or injured or ill to verbally consent to any kind of treatment.
Isn't it also a minor?
Oh, geez, sorry, go ahead.
For implied consent, isn't it also with a minor?
So that's slightly different. With a minor, you can use the reasonable person doctrine if you cannot get a hold of their parents. And that's called en loco parentis or something like that. Oh my gosh, that's like dredging it up from memory somewhere, but en loco parentis, I think is what that means. Is that right? Someone's nodding yes, so it must be right. Good, go on. And then powers of attorney, we have to deal with this more, it seems like, and we have more adults with guardians too, people with chronic dementia, and unfortunately the state is the guardian for a lot of those people, and the state will not limit treatments to even what is reasonable for some of these people. Stuff that you wouldn't normally do for a healthy person who has a terrible condition, you will potentially do for some of these wards of the state who have no cognitive function. So remember that. And they have successfully tried to sue healthcare organizations for withholding unreasonable care for some patients who are wards of the state. So, And then a spouse can provide consent too. So, treating without consent. So people who are incompetent to refuse by law, so minors, are one of those people. And then people who are disoriented, suicidal, or present a danger to the public, potentially cannot refuse treatment. People who are altered. And your general strategies here, depending on the severity of this, would be, to involve law enforcement, get family or friends involved, online medical control. And I would encourage you in some of these situations to actually have the physician speak to the patient. That further absolves you guys of risk associated with obtaining refusals from some of these patients. So, competency versus capacity. So, competence is a legal definition, and it's determined by courts or a judge. So, minors are legally incompetent unless they're emancipated. Some of those things can be if they're married, if they have children, or they're pregnant, they may have additional rights. So to be honest, I don't fully know Montana's law about that, and I always have to look it up. I used to know it for Oregon really well, but now I have to go look it up every time. Does anyone know for sure? I think if you're pregnant in Montana, you actually can consent or refuse treatment. So
That's right.
that's correct, I believe so. A guardian, again, remembering guardians have legal rights to consent for the patient. Capacity is something we determine medically, and that's the ability to make an informed decision, and there's several components to that. So the person who's making that decision has to have sufficient information about the medical condition, and they have to be able to understand the risks and benefits, as well as the available options, and they have to be able to communicate that back to you. And they should be acting on their own accord without undue influence from anyone else. So where would that come into play potentially?
Spouses.
Sorry?
Spouses.
Spouse, like abuse situations? Yeah, so like a partner, family member assault case where someone's refusing care in the presence of the person who may have been the perpetrator, that might be a case where there's some easy things you can do. First of all is separate those people, involve law enforcement, so, right. And then those decisions should be consistent with the patient's personal values. So where there may be cultural things like that where someone would not seek care or not want specific types of treatment, religious considerations there. So. Impaired capacity, so that's what we're trying to determine there. So first of all, they have to have impaired capacity, they have to first be, one of the first things is that they're not, they don't meet the legal definition of, they don't meet the legal definition of competence. So they, are a minor, they have a guardian, something like that. People who are unable to communicate, it's nearly impossible to determine some of this stuff if they can't write or speak to you. You can't use a translator, that may fall into this. Drugs or alcohol, and unfortunately a significant number of our patients fall into that category. Head injury, some kind of toxic exposure, and serious medical conditions, patients in respiratory distress, shock, unstable vital signs. First-time seizures are actually a big source of litigation in EMS too. Patients with established seizure disorder, much lower risk.
So Mike, are you saying that if they've had a first-time seizure, but they're...
First-time seizure and they're post-ictal?
Okay, post-ictal.
Yeah.
But how about not post-ictal?
Not post-ictal, as long as they can, you explain to them what the risks are, that, there's a first-time seizure, and we'd always recommend you get evaluation for that. That this could be like a tumor or bleed or something more life-threatening, and that they should get evaluated for that. And they can explain those risks, and they can explain to you why they don't want to get transport or treatment. Then potentially that's okay. Just saying that that's a patient who may potentially have impaired capacity, especially if sometimes people who have a known seizure disorder, they'll be adamant that they don't want to go to the hospital after having had a normal seizure for them. So even when they are still kind of post-ictal, so that's less concerning in my mind. I'd probably still wait till they get more alert, unless they say that it takes hours or something. And I think we should always remember how we present information. So if you say things like you're having a STEMI or you're having an acute myocardial infarction, people do not know what a lot of that means, even though it's out there. So you need to really explain that to them at a level that they'll understand. And that's different for different people. So trying to quickly determine what level that's at. And that may be something it's like, you may die if we don't take you to the hospital. And then they have to be able to, explain that. So, documentation. In general, these are kind of like the documentation elements you'd want to get for a refusal. So general appearance and their level of consciousness, history and vital signs, physical exam, the suspected presence or presence of actual intoxicants, assessment of their capacity, like so you've done that assessment, do they have the ability to sign the refusal form? Any documentation of any online medical control contact. And then it's a good idea to document why someone doesn't want to go. I don't want to go because it costs too much, or I don't want to get on board your spacecraft are different answers. So, that's going to change. One person may have decision-making capacity and one might not. So, and then a follow-up phone number can sometimes actually be a good thing to document. And they used to require that in our system if we could get it. So, for some of the refusals, or higher risk refusals for sure. And we did have a deal in place where we could do repeat contacts. And if you ever did something like that and documented that, the courts are very friendly on people who I was really concerned about this person, I got their number, I called them back, and I tried to help them arrange alternate transport with a family member or something like that. That stuff, that looks like you went beyond what the standard would be. So. In our old system, we used to have this thing called patient not identified, and I just put this up there because it's something to think about. But so for trauma, there was no significant mechanism, no signs of traumatic injury, no complaints of any acute medical condition, behaviors that places other people at risk, not less than 18, and the person that you talked to was not the original caller. Those were people where we could potentially do something called patient not identified. I think they're not unreasonable to think about, but we don't have that in the current protocol. So what I think you should really be looking at there's no evidence of impaired decision-making capacity. So you've kind of gone through all those risks that they might have. They're hemodynamically unstable, respiratory distress, intoxicated, all those things. They can tell you what you told them, the reason that you thought they should get treatment or transport, and they can tell you what the risks of not doing that were. And they can tell you why they don't want to do it. And then, again, the online medical control, if you're really concerned, using all these other tricks you have, like by enlisting friends, family, law enforcement, sometimes just having another provider or someone they trust. I've even had people call someone who's a relative and say, hey, my name's Dr. So-and-so, I'm taking care of this patient here who's a friend of yours. I'm really concerned about him. I think he needs to be in the hospital, but he doesn't want to stay. And that can be really helpful. So, if they do not have decision-making capacity, having them sign the release form doesn't legally do anything for you. So if you determine that they don't have decision-making capacity, that doesn't help you legally. So, and they shouldn't sign that form if you don't think they have it. And then, make other efforts to see that the patient gets care. That could be contacting a family member who will drive them somewhere or, to the hospital or something like that. And then, potentially patients who are unable to refuse, they may require chemical or physical restraint. So I think probably we should do a talk about what that entails and the documentation that's needed for that sometime soon. But lastly, I put up the checklist deal for this. I'm sure there was going to be lots of questions about how to use the checklist, and it's going to change, I imagine, over time. But I will say that I'm hugely in favor of this. It's not something you need to talk to the person, hold up in front of you, and go through each item. That's not how these are intended to be used. I use these all the time for things like sepsis. I use a checklist to make sure that I didn't miss anything when I'm going through that after I've already started treating the patient. And they're really important. It's the reason that they do this in airplanes. And people who fly thousands of hours do this all the time to go through to make sure they're not missing critical steps or forget to consider something. Top Gun pilots, they do this. They have checklists for every type of engagement. So it's important. And I think it'll take some getting used to. but I think it's, will be helpful. You don't have to use it all the time. I think it'd be helpful to review and route to calls too. But for refusals, it will remind you to, you know, get those key elements. And then just put that page up there, so. And these checklists are gonna be a work in progress. I imagine they'll need some editing over time as we use them, so. Good. Refusals, yes, Des.
Are any other agencies using a similar checklist?
Yeah. In Montana?
No, anywhere.
Oh, yeah, like, Medic One is using it, Denver General uses them. Tualatin Valley Fire and Rescue, where I came from, we used them back when I was there. You know the EMT handbook, your flip book? That was designed by my chief, my EMS chief, when I was there. And I think they're super helpful, so.
We had a lot of good questions about that. I think we were able to answer most of them, but we had one about what is the science behind it? So maybe you can address that a little bit.
Specific
About
science?
checklists. Yeah, about using those and like other agencies using them.
So
What's it
the science
improving?
came from high performance organizations, where they looked at what organizations who are considered ultra high efficiency, high performance organizations, they looked at what they could do for process improvement, and a lot of it came out of aviation actually. But the science is very good that these techniques are really helpful for efficiency actually over time. And you know, not being complacent and missing a step, something you do all the time and just, you know, it's easy to forget. So I'll tell you, we use these for the tactical team. We have a checklist for different types of operations. Like, we need to establish this, we need to have this stage, we need to have this, and we have that set up for all of our operations. And I think it's something that's really important, so. Yeah.
With regard to refusals, sometimes you hear the phrase thrown out quite a lot about no patient contact. Do you have a vision for what no contact means, whether, because I've seen that vary greatly. You're there for 10 minutes participating in the refusal decision, but you say, I'm tapping out because I didn't touch this guy. Or, you know, I mean, where would you see a no contact kind of a disposition where you write off that I came and I left and didn't do anything?
I think when you, if you get there and fire's got a set of vital signs for you, and the person says, I'm not injured, I didn't call, I was just passed out in the bushes here, that's pretty reasonable. They have normal vital signs, they can tell you that they don't have any medical problems. That would be reasonable if they're not overly intoxicated. So if they're able to tell you that, yeah, I'm fine, I understand that I could have something going on, if I'm being transported, I could get worse.
But that would be us actually contact with the patient if we were hearing that. I think in terms of like, when can we say, cancel no contact, you know, like if I pull up to the door and I've got the fire department inside and the officer like, then comes outside and says, doesn't wanna go, we're taking vitals, but she's definitely not going, and then is that okay for us to, cause at that point, I'm gonna say, okay,
Yeah, I think
we're out of
that's,
here then.
I think that's reasonable, but then the onus is on them to document it.
Right.
Yeah. So, but if you're in there helping,
Document that they told us.
yes, yeah, I mean, it needs to be like a one-line statement. Arrived, fire department, had assessed the patient, refusal was obtained, did not make contact with the patient. So, something like that. Is that,
I mean, there's just such a broad usage of that term that, like, I had a fellow one time years ago, who doesn't work here anymore, so I'll try to figure out what I'm talking about, who actually took the blood pressure, didn't want to write the whole report, so he tells 911, we're clear, no contact, and I just looked, it's like, you touched him.
no.
But it was a mechanism to write a baby report instead of the whole cover your ass report.
Yeah, you should never document things that you didn't do, and you shouldn't not document things that you do. So if you say, I didn't make contact with this patient, but they can later identify you, and they say, no, you're the one who took my blood glucose, or, you know, took my blood pressure, or, you know, anyways, that would look bad later. Especially if another provider from a different agency says, vitals were obtained by, you know, so-and-so.
Investigation cameras.
Yeah. And I don't know that there's, there's probably a chance in the future someday that we're gonna have all this recorded, so, yeah. I was gonna put up a couple scenarios, so always fun. I took these from another agency because I didn't want to use things that had happened here, but I thought they were good. So there's a multiple vehicle accident on interstate. EMS arrives and they find numerous occupants out walking and one vehicle on its side. The police have one person in custody in the back of a patrol car. They tell the arriving unit that there's no injuries and they can go available. And EMS clears the scene. So this actually happened somewhere. It's in a southern state. So 30 minutes later, they get called back because the person in the back of the patrol car, a 52-year-old male, is unconscious and unresponsive. It was later found out to have a subdural and expired 3 days later. So how would that look in court, first of all? Not that you should think of everything about how it will look in court, but
Sounds like the cops in trouble.
Police aren't medically trained, so they can't clear us.
Well, they are to a certain extent, right? You have
They're in charge.
advanced first aid or some such thing like that in the academy, but,
yeah.
right?
And I think that you arrive on scene and you see like a relatively significant mechanism, potentially. Probably I would double check to see. Now, if those people had already been assessed by fire and they had normal vital signs and stuff, that's a different situation. And then I think that, you know, it's likely that these people, hopefully we get medical clearance at the hospital, but, so that looks potentially bad. And then you want to, I think you would definitely want to at least assess who was the driver of the vehicle that rolled over. You know, you don't even know that much information from this. So it's easy. It's sometimes easy to take things at face value and then get anchored that, oh yeah, everyone's okay, I'm clear. So
Wait, Mike, can you just go back? So in the ideal situation, you would like to see us make contact with that patient, with all the people that were involved, and
I think even if it's just quickly, you know, it's a significant mechanism. It's a rollover at
Yeah.
highway speeds.
Okay.
So I think they need some kind of assessment done.
Yep.
So, and it's likely that you'd have other people there, another fire apparatus to kind of help you quickly assess people and then determine if there's anyone who's injured. I don't know the whole circumstances of this situation, of course, but or how their system works either, but I saw this case presented, and the fire department and the ambulance ended up getting sued successfully for this case. So, and I imagine the police department did too, because they probably brought everyone in, right? So, and prisoners are a particularly at-risk group for lawsuits too. You know, so someone who's in law enforcement custody, they don't maybe get as thorough an assessment, or maybe they're unpleasant for other reasons, alcohol or behavior. So just at-risk things to think about.
Speaking for the officers that I know around here, none of them would have a problem with us asking to assess the patient, but I would recommend having the officer stay there so they don't have to go through the bother of subpoenaing a report or anything like that. If we're just checking vital signs and mental status. Is that right?
I think that's reasonable. Do you have any injuries? Can they talk to you? Are they acting normally? Do they appear intoxicated or altered for other reasons? They have normal vital signs? No obvious signs of trauma? So,
From a legal standpoint, these officers we can't tell them anything our patients say, right? They have to subpoena our report, and that's a long drawn out process, and it takes time to process charges and all the other stuff too. So in that kind of scenario, I'd say have the officer stay there, and the guy sees them staying there, and then they don't have to worry about going through that.
technically, if they're in custody, the law enforcement officer can consent for them, so.
Cool.
So I might have missed it, but what is the capacity for law enforcement to cancel us? Like, what kind of medical background do they have as far as like looking them up and down and be like, they're refusing, they seem like they're all there?
Not, some have none, essentially, whatever they get at the, state law enforcement academy, so.
I think that we, like a lot of times when we're staged and they go in for something, we hear back that law enforcement advice, most of the time, you can enter, but from time to time, they will say, medical can clear. I'm assuming that they've gone in there and there wasn't what it was said was happening, there wasn't assault or whatever.
Yeah,
some form of reasonable person thing
Yeah,
that they have
yeah,
figured
I don't
out.
wanna start questioning them.
Yeah.
I don't wanna say, no, we're going in or whatever, you know, so I guess we trust them.
Oh, they love that.
Yeah.
I kinda wanna hit, I think that,
Especially,
You probably know what they teach at the academy for.
it's terrible, it's
I
terrible.
know.
I think they're overcautious in a way though, because again, with partner family member assaults, we have to prove that this person was hurt. And by bringing that ambulance in and having that, like, we encourage them to go to the hospital for stuff like that. And I think you see it more on traffic stops and DUIs. We want that blood sugar taken. We want to prove that these people, you know, are alert and ready at times for, and there's medical documentation stating that. So I don't know in other states, but I think in Montana, Missoula County alone, I think they're overcautious.
So when they tell us.
Compared to Portland, or Brad, you know about Denver, right?
Yeah.
They did a lot of these assessments at the jail, right? In Denver? Yeah, they had a medical staff there that really was pretty good. And you didn't have to deal with those folks at all. Not like here, so.
Isn't there a nurse?
There's also been times when I've requested
Sounds clear to me.
you want me to do. Do you want me to assess them and take them? Do you want me to, he's like, if they're gonna refuse, I want you to get the refusal. It says, that's a hot potato. They want me to catch it, because then if that guy croaks out, they can say, oh, look, we tried to put him in the ambulance, and he wouldn't go.
I would say, yeah, the attitude here I think is very different from other places where I've worked, and they're, I would say, overly cautious on medical clearing patients. So, which is fine. It's just a different way to do it, so. And I think part of that is that they don't have the resources at the detention center that they have in larger systems. That's probably a big part of it. And then we also don't have any kind of, you know, sobering station like they do at a lot of other places as well, so. If anyone wants to take charge of that, I would advise it. So the next one, a 76-year-old guy drinking all day, has a fight with his sons and wife, and during the argument, he says he wishes he was dead and then clutches his chest. And he has a known cardiac problem. He takes nitro, and the family calls 911 without his knowledge. And when the ambulance arrives, he says, I didn't call you, get out of my house.
Law enforcement.
Yeah, so that'd be one way to, what would they do for you?
Well, you're gonna at least make sure that none of us get injured, which is important. But, and by doing that, we're gonna make it safe for us to approach that individual at some point and do the assessment that we will need to do on him. It sounds to me like that guy's probably gonna end up going to the hospital because he's altered, one way or the other.
Yeah. I think there is a really helpful, actually, aspect for law enforcement for this particular one, is that this guy told people that he wished he was dead.
Yeah.
That's what
So-
you wanna confirm as a provider, just ask him, did you say that? Yeah, okay, well, now you lose.
Yeah.
If he says no,
Those altered mental status domestic things are what gets cops killed, so
Yeah.
we need to at least go in and make sure
Yeah.
they're not, you know.
so we don't want them to get killed either.
So good, that would be a good tool, that's probably the tool I would use to approach this situation, is like, look man, I don't have any choice, the state law says that the police, have to take you to the hospital to get a mental health evaluation if you say you're gonna hurt yourself.
Now, can I just ask,
So,
Mike, because he
yeah.
doesn't, I just want to get a technical question, he didn't actually do anything that, he just says he wants to die, does that matter? He didn't actually say, I want to die, I took a quarter of an aspirin to kill
Yeah.
myself. Is
But
that
if you say that you're concerned someone's expressing suicidal ideation, it falls under the state law under what they call emergency situation. And in that setting, they can be held up till the next business day for mental health evaluation by the MHP in this system, so, yeah.
And that,
So what if they, like, it seems like him being intoxicated is kind of like an easy way out to get him to the hospital in this case, but say for example, it was, sober as a judge's bird, and there wasn't any of the other things, and he just told his family, I don't want to be alive anymore. And then law enforcement's called, and from that point on, he denies it that whole time. And he did in fact say that, but basically it's his word against theirs, and then he does, go through with it. I mean, is that to the point where?
Some of that will be at the discretion of the officer then. There's probably some officers who are gonna say that you have to go, and they'll, and others might not push that. I would say in this system, they're probably gonna err on the side of transporting that person if there's any concern about it, and they'll say that the mental health person has to sort this out. So they'll further say, look, I'm hamstrung by the law, I have to take you in, and then we'll have this other guy help sort this out, and I'm sure he'll be able to help you out. So each person's kind of putting it off on the next level, But that's one way to approach this. The other is to say, no, do an assessment of, does this person have the, decision-making capacity? Like, can they explain to you why you're concerned about them and what the consequences of not going to the hospital for a heart attack are? It could be considered. It could be concerning. I mean, he took vasoactive medication, right? So it all depends on how you document it. Okay, so a couple from out of town's hiking. The wife has a possible seizure per the husband, who describes eyes rolling back and being disoriented. She's lethargic, but oriented ×4, and says she's fine. She wants to get assessed only. And the only finding you find is incontinence. States she doesn't want to go to the hospital and refuses transport.
But you have to explain the risk to her and allow her to make an informed decision, advise against her not going to the hospital for sure.
Yeah, there's a couple, and it may just be a simple seizure too, but it's a first time seizure, and you can explain that this could be things like a mass or something else, and that all first time seizures we recommend get evaluated in the emergency room. You can use her husband to help you, right? Where you'd be like, I'm concerned about this, I really think she should go. He may be a big advocate for you. Alternately, he might not, I don't know. And then this is one where if they're still refusing and they can express all that stuff back to you, and they have normal vital signs, normal blood sugar, I would consider, online medical control talking to the patient. So.
What's the general sense of the docs that you work with getting in that? I know that some don't.
I think it'll be hard to get used to for some of them.
Yeah.
But it's something we should be doing more of. So, and that's because these particular scenarios are when you're really that's one of the biggest things that online medical control can do for you, is help you with these kind of more difficult decisions. Does this person have decision-making capacity? So good. I think that's all I had for those. Any other refusal questions or?
Just to reiterate, if you actually use a refusal form and fill out most of the questions on there, it's pretty good from the law firm.
We're not filling them out super well. We're not doing it super well for city fire either, so we need to be really good about that. So, because this is where we're taking on a lot of liability.
We have to have our own refusal for you guys. We cannot accept the paperwork from the fire departments, their refusal form. If we make patient contact and you're refusing, you have to fill out our refusal form.
So
That's the only thing that keeps us from a legal standpoint out of the liability.
Okay, so this was probably a year ago. So it was a 911 call to the VA clinic, and the doctor at the VA clinic wanted this guy to go to the hospital because he came in complaining of chest pain. We get him in an ambulance, and he goes, I'm not going. I refuse to go. So we're trying to explain to him, well, the doctor said that they really want you to go get evaluated. So I went in there, and because I wasn't comfortable with him getting a refusal, so I went in there and said to the doctor, or the nurse, I said, this guy is adamantly saying he doesn't want to go to the hospital. So she was, she came out and talked to the guy in the ambulance, and the patient was like, you really need to go. We tried everything, and so we got a refusal from him, but I was nervous getting a refusal from him when a doctor in the VA is the one who said this person needs to go. So what do you do in that kind of situation?
Unfortunately, people have autonomy in our society to make those decisions if they have decision-making capacity. So we had a case in Portland of a guy who had a STEMI on 12 lead who refused to go. And what they did was they waited around the corner, and then he passed out. They came back and picked him up.
Probably scared him too.
Well, that was kind of my thing too. The guy's probably going to pass out eventually sometime today.
But then you could encourage a family member, look, if you're not going to go with us, I don't think that's a good choice, but why don't you have your friend drive you? So,
Whatever it takes to get them to go.
so you're making a reasonable attempt to get them, an alternate means of transport to the hospitals. Yeah.
Real cool question. It said in the thing that they needed, also the patient needed a copy of the refusal form. I know fire has the carbon copy copies, but we only have a single sheet.
I think that was for our fire department ones, so, sorry.
Is that not
I'm
applicable
getting
for
the
us,
same
any of us?
Was that?
Is that not applicable for us? then?
No, because I don't think you guys have copy, do you?
No,
That you give to the
our
patient?
refusal forms are no, they're just two-sided.
So it's two different forms that if the fire department needs to get a refusal, they should get one on their form, and you should get one on ours.
Yeah.
That's how it works.
Basically, your patients sign in twice.
We'll both be sued, so we both might as well get a refusal.
So get your signature first so they're not annoyed at you when you ask.
That's right. It's a fight to get it first.
That's the rule.
While they're doing the checklist, we'll be bounced.
So one time at the hospital I used to work at, there's this thing called the Medical Resource Hospital where all the ambulances in the city were routed through a switchboard at our hospital. And so one of the doctors who was working, super serious person, on April Fool's Day, I took one of the phones that we all carried out into the ambulance bay, and then I called in to the resource hospital and told them to connect me with her, and they recorded it all. And it was, I said like, I was like AMR 210, and we're on like Burnside with the guy who just had a cardiac arrest, and he'd like to get a refusal. And she's like, what? And I was like, yeah, we arrived, he was in VFib, and we shocked him one time. He got a few chest compressions, and now he's alert and awake, and he says he wants to go home. And she's like, what? Yeah, he says he was just in the hospital there, and you guys didn't do anything for him. And so I kept leading on, and then finally she figured out that it was. And she goes, can I talk to him? And I was like, hold on a second. No, he does not want to talk to you. So, anyways. It's pretty good. All right. Chest decompression